right, we are live, and so I'm going to turn it over to Mac Burnham, who is our MC, host, moderator, whatever you'd like to name him for the day. Thank you so much, Mac.
Okay, hi, I'm Mac Burnham. I'm a co-director of EPLink, the OBI's Epilepsy Research Program. Normally at 4 on Fridays, I'd be announcing a talk for scientific researchers, but in these weeks before Purple Day, EPLink, in collaboration with the Epilepsy Toronto, has decided to open these meetings up to everyone. So welcome everyone to the first Power of Purple seminar. Today we'll be hearing about epilepsy surgery and other treatment options. Our speakers will be Dr. Taufik Valiante, Jordan Shuler, and Gary Collins. After these talks, we'll have a question and answer session, so please hold your answers till that point. But you're invited to submit your questions into the Zoom chat box, or if you're watching on Facebook Live, you can submit your questions into the comments section. As mentioned before, if you're attending through Zoom, there will also be a chance to discuss these topics further in a breakout group session. Okay, with that, I'd like to introduce our first presenter, Dr. Taufik Valiante, who joins us from the Toronto Western Hospital, where he works as a neurosurgeon. He's also a director of the surgical program at Krembil Research Institute and an associate professor of neurology at the University of Toronto. Taufik?
Good afternoon, everybody. I hope you can see my screen. It's a treat to be here. Today's about epilepsy surgery and other treatments. I would love to give a more holistic talk than just focus on epilepsy surgery, but today my task is to talk to you largely about epilepsy surgery. It's no mystery why we're here today, as you know, it's an auspicious day on the 26th of March, which is Purple Day, and you know, clearly the purpose of this, like much of our activities when we think about the epilepsy community, is really about raising awareness. And you know, I'm always reminded of the literature, which really speaks to, you know, knowledge is power, where we do understand that the more one understands about epilepsy, the individual with epilepsy has a better quality of life, and in fact, those around them are much more understanding and create a better environment for those individuals. So for the uninitiated, although I know probably many of you understand what epilepsy is, epilepsy really is a disorder of the brain, and the brain is an electrical system, and you can think of it as sort of having an electrical storm within the brain that oftentimes occurs unpredictable for the individual, although there are patterns that have been sort of described for individuals with epilepsy. And really the major effect is on all spheres of an individual's existence. You know, it's really the prototype of a chronic neurological condition which affects individuals biologically, psychologically, and socially. And this is just a slide. The text is not that important, except to say that epilepsy is a very common condition. It's argued to be the most serious common neurological disorder in the world. And, you know, Matt can remember when, you know, when we used to talk about comprehensive epilepsy care, and I'm always reminded at that time when I give a talk about epilepsy surgery, because at that time, really, and even today, the major innovation when it comes to epilepsy surgery is access. And so I think, you know, we're very, very excited that we have now one of the first regionalized approaches to epilepsy care in Ontario. And the interesting thing about this provincial epilepsy strategy is that the endpoint really is to get individuals to surgery. And what that is a manifestation of a system that's working well, that can guide an individual through the entire care pathway to surgery. So I think that, you know, it's been a long time coming, and I think that this for me has been really one of the most exciting aspects when it comes to epilepsy surgery, because when we look at the literature, it's clear that individuals who obtain their treatment of their epilepsy, particularly from a surgical point of view, earlier in their disease course, do better from a surgical perspective, are more likely to come off their medications, are more likely to benefit from a a social perspective. So this is what really is that for me is one of the most exciting aspects of epilepsy surgery that's really happening in Ontario. I'm not going to go through it. I just put these kinds of slides up just to show you sort of the things that we look at. And this is really an important trial that came out of London. And the long and short of it really is that when we look at all the treatments for epilepsy, if somebody is a candidate for epilepsy, nothing works better than removing that part of the brain that is causing seizures. I know Mac would often distill that down whenever we would go out and talk about these the comprehensive epilepsy approach. And just to sort of summarize it, it's a complex process to bring somebody to epilepsy surgery. It's a multidisciplinary approach. It's a very resource intensive. We have a very large team at the Western and other surgical centers, which involve neurologists, epileptologists, neuropsychologists, radiologists, nursing, psychiatry. And then at the end of all these kinds of tests, potentially somebody can become a surgical candidate. And oftentimes this does not require any kind of invasive procedure. And I always joke that, epilepsy surgery is like real estate. It's location, location, location. And really, that's really the goal of the pre-surgical workup, which is to identify that area of the brain that is generating seizures. Now, when we do all these pre-surgical tests, sometimes the picture can be rather complicated and things aren't sort of fitting together. And that's where I just want to mention sort of the first type of epilepsy surgery that we do, which is really sort of invasive recordings to understand where the seizures are coming from. And it's important to remember that this doesn't happen for every individual. Most of the time, about 2/3 of the time, we can find the area that is generating the seizures without going to an operation such as this to implant electrodes. So this approach is actually, it's new in the sense at the Toronto Western because we have started to do this using robotic technologies. It is a well-established procedure. It's called stereo EEG or SEEG that people might have heard it in that context. And I do this in collaboration with a colleague of mine who's a neurosurgeon with an expertise in deep brain stimulation. And we think it's a really wonderful partnership between a specialty which primarily is interested in neuromodulation, which is what Dr. Sunil Kalia does, and myself, who's involved primarily in the care of those with epilepsy. And so once we identify using this technology where the seizures are coming from, or if we identify where the seizures are coming from without implantation, then the next step is to remove that area of the brain that we think is causing the seizures. Now, if I was sort of giving you a typical talk, I'd probably go through all the details of the conventional way of doing this surgery, which is the typical open surgery where we do make a cut in the skin and remove bone and then remove the temporal lobe. But I want to talk to you about today, which is a newer technology, which in fact we do offer now at the Toronto Western Hospital through a donation, through philanthropy. This device was purchased, and many of you are probably aware of this. It's a way of removing or ablating a part of the brain relatively non-invasively, which involves placing a catheter to the area that you want to remove, and then basically heating that area gently. And very interestingly, you can measure the temperature at which you're heating the brain actually with MRI. So this is done in an MRI machine. And that area which you think is generating the seizures is then ablated by heating it. And this is called laser interstitial thermal therapy. We provide this as an option for individuals, for a certain subset of individuals with very, very specific indications for when we do this type of ablation. And I'd be happy to talk more about that if people have questions. Now, you might think that, it's less invasive, there's a catheter that goes in, must be less risky. In fact, whenever we enter the brain, whenever we enter the skull, the risks are almost about the same. Now, this surgery as compared to the open surgery, which I do, is considered low risk, but there are risks nonetheless. And of course, these are risks that, one doesn't want to minimize. The risks can be generally thought of sort of general to neurosurgery, and then those are specific to where we're actually removing areas of the brain. And here we see an example, which is actually the most common type of epilepsy that we deal with, which is temporal lobe epilepsy. And the kind of things that we worry about in the temporal lobe are things like memory in particular, and language if we look at the more superficial parts of the temporal lobe. So of course, nothing is without risk. Even when it's minimally invasive, there are almost similar risks to open surgery. And, this is something that we've learned through work with Cynthia Milburn. When we do talk about different options, is not to minimize, the reality, which is that, there are, huge benefits to these types of things, but there are also the attendant risks if you choose to undergo this procedure. Milburn. What's that? Sorry. Oh, so as I mentioned to you, really when we can identify that specific area of the brain to remove, then really that's the best treatment option. And when I do talk to individuals in the clinic in regards to surgery, if you look at an individual by the time they've come to my clinic, they've probably tried 3 or more, probably many more medications. And typically for somebody to be seizure free on a new medication is usually about less than 1%, whereas surgery, the typical chance of being seizure free after an operation is close to 60%, if not greater. So there's really no comparison once an individual has been deemed a surgical candidate between continued medications and surgery. In individuals who we cannot identify a specific area, or there's multiple areas generating seizures, or the area which we want to remove is in an area which we can't remove and somebody really depends on, then we think of other types of approaches, and neuromodulation, which you've probably heard about, which comes in this specific flavor, which is vagal nerve stimulation. And it's important to note that this is not a brain operation. In fact, involves placing an electrode around a nerve in the neck on the left-hand side, which is then attached to a battery system here. And it has, of course, it does not have the risks of doing brain surgery, but of course it does have other surgical risks, which are minimal as well. The really cool thing about these devices now is that they're starting to get smarter and smarter. And this device, in fact, can actually sense changes in the heart rate and use that to sort of try to understand if somebody's having a seizure. And so these are sort of devices which, if you want to talk maybe from a little more technical perspective, are called closed loop devices, which actually sense things that are going on within the body, within the brain, and can trigger or stimulate the brain accordingly, with the understanding that extra stimulation may help either stop the seizure or reduce the strength of that seizure. Just the last few minutes, I wanted to talk about sort of the exciting things that are happening from a research perspective and sort of larger scale endeavors. And I think that it's important to note that in addition to the incredible work that's been done to regionalize and standardize the care of epilepsy through the province of Ontario, is EPLink in the OBI, where many of us are part of EPLink, which is you could think about the provincial epilepsy strategy as sort of the clinical arm of epilepsy, then this would be the research arm from a provincial perspective. And EPLink is mandate is to improve the quality of life with those with epilepsy. And there's different facets to EPLink, and I happen to be part of the brain monitoring and modulation for epilepsy group. And this really speaks to kind of the device that I just talked about before, which is that, we have a strong interest in sort of developing the next generation of devices that are better at sort of understanding brain activity, understanding when the brain is slipping into a seizure, and stimulating the brain to sort of come out of that. And along that line, I think that, when I speak to individuals in my clinic, and, sometimes I'm unable to, provide them an option for their seizures, I like to, at least for myself, comfort myself, maybe comfort them, is to, let them know that we're very actively pursuing new ways to treat and manage epilepsy. And Crania is one way. It's a large CFI grant where we've created a center around these types of neurotechnologies. And the last thing which I want to mention, because I think the time is up, 10 minutes, is that it's very important, as I sort of began with the first slide around community, we do really have a community of scientists. This is my own lab, but we collaborate with people in various different disciplines to try to create that next generation of neurotechnology. And I think on that note, it's 4:15 and I'm going to stop there.
Okay, thank you very much, Taufik. I remember Taufik as a graduate student in Dr. Cullen's group. It's been a real pleasure to watch him grow into Ontario's premier seizure surgeon. Our next presenter will be Jordan Shuler, who underwent brain surgery with Taufik in 2014. He's currently working as a digital education specialist at the UHN, and he'll be sharing his story about living with seizures, his diagnosis, and his brain seizure surgery experience. Jordan?
Thank you, Meg. And thank you, Taufik. It's a pleasure to be here with you, with everyone. And I've been tasked with sharing my story from symptoms to diagnosis into surgery and then recovery. So my story begins during my university undergraduate years, and I recall experiencing intermittent episodes whereby I felt like time was stopping, literally like the clock was stopping, and I was still, and the world stood still momentarily. Unbeknownst to me at the time, they were what later would be diagnosed as absent seizures. They were not harmful, not even uncomfortable, quite unique. And so I didn't pay much attention to them. The years went on, and about maybe 15 years later, the frequency and duration of those episodes increased. My wife started to notice, and they started happening not just at home, but driving on the DVP, or while I was teaching at the college, playing sports, on a bicycle, riding my bicycle. So it became serious and something we needed to look at. So we went to my GP, and then from GP to a neurologist, and got diagnosed eventually with what's called a cavernoma in my right temporal lobe. So abnormal blood vessels constricting, and blood would spill out of those vessels and interrupt the blood flow, and if my memory serves correctly, the electricity of the brain. And I would basically go onto autopilot and turn off, sometimes for a few seconds, sometimes even up to a minute. And the neurologist started putting me onto medication, and over time it just became trial and error. One didn't work, had different adverse reactions, so I would try another one. And prior to that, I didn't realize how powerful head medications could be. Each one had really strong side effects, emotional in some cases, anger, or even suicidal tendencies. I had never thought that a medication could cause such strong reactions. So eventually I replaced that neurologist with another one. It wasn't working out. So I mention this because those of you who are going through the process now, that don't be afraid to, find the right doctor that feels good to you. Eventually, the next neurologist turned me on to Epilepsy Toronto, and that's when I met the queen, Rosie, who works at Epilepsy Toronto, and an amazing advocate, support, and just became a friend and a wealth of information. I can't speak highly enough of Rosie's work. And Epilepsy Toronto became for my wife and I, our source of support and knowledge. And met other people who had gone through similar or dissimilar paths, but all dealing with seizures. Rosie suggested that I consider surgery. So I asked my neurologist to set up an appointment with a surgeon, and that's when we met Dr. Valiante, who also is an amazing, a pillar of the community, who's a wealth of knowledge and so supportive and an amazing bedside manner. So he laid out all the options and made it very easy for us to, my wife and I, and also my mother and sister and my mother and father-in-law, to make a joint decision that we would go ahead with surgery, because Taufik made it, so clear. Any questions were answered, and we signed up. So it was about a year from signing up until surgery date. And Dr. Valiante removed partial temporal lobe on the right side and the hippocampus, including the hippocampus. And surgery was successful. The surgery itself, if anyone is out there considering it and you have some fear, surgery, I wasn't awake for it. There's no pain. Very easy. The recovery was exactly 2 months. I remember on the end of the 8th week, I was at home. The end of the 8th week, I woke up without any pain. But it was during those 2 months where I was really completely reliant upon the support of others. We took turns with family members, my in-laws, my mother, my sister, my wife, who would come in, and each would spend, days or a week with me at home, because I was in bed. I couldn't go on my own. I was in a wheelchair. My head was inflated. I couldn't fit my glasses on my face. And it was uncomfortable at times. I couldn't even get myself a glass of water. I was completely reliant upon the care, the kindness of others. And after that, those 2 months, everything seemed to return to normal. My head returned to a normal size. And I was able to go out, even get on a bicycle again, and slowly return to normal life. And since surgery, I have not had a single seizure. I've returned to sports. I play volleyball. I'm diving headfirst into the sand, even, things that we never thought I would do again. But life has returned to normal. My memory's improved. And we were worried that maybe my personality would change before surgery, and it turns out that didn't happen. In fact, I like to joke with my wife that maybe Dr. Valiante made me even more romantic for my wife's benefit. So I strongly recommend the surgery if Dr. Valiante says that you're a candidate. It was a great life-changing event and made me stronger than I was previously, and get involved with Epilepsy Toronto and rely on their knowledge and support. So, communicate with your family and let them be a part of your journey. I wouldn't have been able to do it without their support. Just too much information, and during that recovery, I can't do anything for myself. So let it be a journey that your whole family walks through together, so that they can be involved in your decision making, and that you can rely on their support afterwards. I'll be available for further questions afterwards, of course, and even further, you can always reach me through Rosie at Epilepsy Toronto.
Thanks, Jordan.
Thank you for sharing your story with us, Jordan. Our next presenter will be Gary Collins. Gary's president of Epilepsy Canada, and I had the pleasure of working with him when I was on the board. He has lived experience with epilepsy, and he'll be sharing his journey having taken epilepsy meds, about the side effects, and how research has been beneficial for him in developing new drug therapies through Epilepsy Canada. Gary?
Thank you so much, Mac. It's a pleasure to see you again, as always. And thanks for everyone for joining us today. First off, Jordan, great story. Love to hear those stories. I hear them every week and every day. So anyone watching today, this might be a repeat of Jordan's story. We're all the same. My story, I spent 25 years in the high-tech industry, and I began again, like Jordan did in my university days, when I was 20, I had a seizure and I didn't know it. I was by myself. I thought I fainted. It had happened a couple of times over the next few years. And it wasn't until about 6 or 7 years later that I was working in the high-tech industry and I was on a trip and I came back and I had to go in the office early. And when I went in the office, went to print off a document, came back to my desk and had a seizure and hit my head. And at that moment, someone was there to see it. I was then taken to the hospital to Mount Sinai and had 2 seizures on the way down in the cab. And so I was therefore diagnosed. At the time, I was married to 2 kids, new family man, was very ambitious as a business executive, wanted to grow my career. And so for the next 25 years, I didn't tell anybody. I was afraid that if I disclosed what my condition was, that people wouldn't trust me. They would think that I wasn't capable enough to have responsibilities. So I kept it myself. Typical of all epileptics, I lost my license for 12 months, and I was in a job that when I was traveling to the U.S. Extensively. So I had to have someone come with me to drive if I couldn't get around that city in a cab. And at the time, I was prescribed Valiante, and it worked for the most part. Like everyone else, I was lucky that my seizure medication stopped the seizures. So I wanted to talk today about what I describe as the forgotten 70%, and also to talk about who's responsible for your healthcare. 2 significant things. So when I took at Valiante, and I had my GP was a good friend of mine, and I had a neurologist at the time, and it was prescribed. And over time, it just began to accumulate the side effects. And about 2015, I was really experiencing a hard time. As Jordan identified, the side effects can be crippling. So at that time, I had stopped doing sports. I had lost a balance, lost coordination. I was having sleep problems. I was having nervousness. I had tremors in my hands. And things weren't going so well. And my life seemed to be on a downward spiral. I just couldn't understand what was wrong with me. And so in 2018, I had the great experience of doing a presentation with Dr. Peter Carlin in Sarnia, Ontario. As a president of Epilepsy Canada, we fund research across the country. Peter was one of our research recipients. And Peter and I known each other since 2010 when I joined Epilepsy Canada. And we're sitting down at dinner, and Peter was curious and asked me what med I was on. And so I talked to him about it, told him I was on Valiante. And he then started asking me about my side effects. Do you have this? Do you have that? Do you have this? Yes, I had all of them. And then the critical question was, he said, how are your mood swings? And that one killed me. Because by that time, by 2018, I could go from happy to sad in a millisecond. And I couldn't understand. My brain, at the time was saying, how could I act so irrationally to such a small situation? And so I was really frightened. So when Peter asked me that, and he just said, you need to really review and look at your current medication, what it's doing to you. So because I'm on the board at Epilepsy Canada, because I work here, I want to make sure there's no conflicts. By the way, I don't vote on funding episodes at Epilepsy Canada. I'm operational manager. But so I asked the board if Peter could be my neurologist, and they agreed. And so the next 2 months went through a complete battery of tests with Peter. I failed all of them, every single one. And then Peter came back and suggested and prescribed a new med for me. And at the time he prescribed lamotrigine. And he said that there's likelihood that I would feel lighter, better on the other side of it. So we went through that process of changing. And I just have to say that within 2 months, it was like someone took a black hood off my head and I could see again. It was, the fog had gone. It was just so enlightening to be able to experience life again as I was normally. So that was 2.5 years ago. Since then, I've lost 35 pounds. I've returned to sports. Loved your story, Jordan. Ski, snow ski, play tennis, hike, play golf, squash, super active, and just leading a wonderful life. It's been remarkable, the change. Peter advised that would happen, and I really couldn't believe that it did. So, and it was interesting for me because I'm in the business. And yet, so in the since 1985, when I was diagnosed, there have been 15 to 18 new meds for epilepsy. And so at the end of this, what I really became aware of is that, we are ourselves responsible for our own healthcare, to be our own health advocate. We need to push our medical support teams to reevaluate on a periodic basis how we're feeling and ensure that we're dealing with an epileptic neurologist. One of the questions that Peter asked me if I had been telling my neurologist how I was feeling, and the question I always got back from them was, are you having seizures? And my answer was no. But they didn't ask me how I was feeling, or when I did complain about how I was feeling, they simply came back and said, well, if you're not having a seizure, we should stay with the same therapy. And so I started to feel like I was the one who was complaining until that day that Peter brought it to my light. And so today when we talk to people, we really say, push your healthcare professional, get them to relook at your situation. Life changes. So for me, I'm a living example of great research happening day in, day out. And even for those 70%, that's me, whose seizures are mostly controlled by medication, I think it's a great opportunity to change your life and be part of it and to see the change happen. I worked with and met Taufik and Peter Carlin, and just they're great neurologists and scientists across this country, which is fantastic. So I'm very happy and share some of the things that Jordan went through, but living on the other side of a new normal life, and it feels really good. I will make one plug, if I can, Mac, that Epilepsy Canada made a recent announcement in January that we've formed a strategic partnership with Cure Epilepsy from the United States. We think this has significant benefits for Canadian researchers to have access to greater pools of money, and I think to our donors across the country, and most importantly to the 360,000 Canadians who are living with epilepsy. Our shared objective is to find a cure globally, wherever that can be. So very happy to be part of this, and thank you for letting me tell my story.
Thank you very, very much, Larry. And thanks to all our presenters today. We're now going to move on to our question and answer session. Just a reminder that if you have a question, you can submit it via the chat at the bottom of your screen if you're participating through Zoom, and in the comments section if you're watching on Facebook Live. We'll do our best to get it to as many questions as we can. And I think we have one up already. Question would be for Taufik. How do you decide what kind of surgery is needed for someone with epilepsy?
So it's there's I could probably categorize it two broad categories. So I could, in the context of temporal lobe epilepsy, it often is a very standard anatomical type of procedure. It often involves removing a stereotypical aspect of the temporal lobe. As soon as we move outside of the temporal lobe, then it becomes more what one would consider a tailored procedure, where you'd have to sort of map out exactly where it is. You often are adjacent to specific areas of function, and in those situations, the surgery might have to be really tailored in regards to what is removed based on the pre-surgical workup, as well as based on function. So oftentimes these are surgeries where we'll map motor activity or sensory activity and language are sort of the main functions we try to avoid when we're operating outside of the temporal lobe. And then when it comes to neuromodulation devices, then that's again, really indicated when an individual is not a receptive candidate. So it becomes sort of the default treatment if we can't find a specific focus, or there's multiple foci from which the seizures are coming from. So that's kind of the broad categories. And I guess maybe I'll just, for completeness, I'll say that the intracranial recordings are done as sort of as another operation, if you want to call it that, but not really for epilepsy, but as a diagnostic test. And that's when our pre-surgical tests don't align with one another. They point us in a different direction, or it seems very complex from the non-invasive test. Then we really go on to the invasive recording. So that's kind of the decision-making for the surgical interventions.
Okay, there's another question which is related. You have talked about surgery for patients with temporal lobe epilepsy.
Yeah.
Is there anyone else who might be a candidate? Can there be other surgery on other lobes of the brain?
Oh, for sure. You know, actually, Jordan mentioned about a cavernoma. His cavernoma happened to be in the temporal lobe, but cavernous malformations can occur outside of the temporal lobe. And whenever somebody has like what we call a lesion that way, then we often think they're very good surgical candidates from a epilepsy perspective. So yes, for sure, if the lesion that we see on the MRI scan is anywhere else, then for sure, we still, you know, those are individuals are candidates. And even people with normal MRI scans can be candidates if we can localize, again, where the seizures are coming from. And so although temporal lobe forms the majority of the surgeries that I do, about 30%, 30 to 35% are outside of the temporal lobe. In fact, though, that this is actually quite different in the pediatric population, where most of the operations are actually done outside of the temporal lobe, and a smaller percentage are done in the temporal lobe.
There's a question about operating on both sides of the brain. Why is it so dangerous to operate bilaterally? And could there be perhaps a laser surgery on both sides of the brain?
Yeah, so that's a great question. So I assume the question's about temporal lobe epilepsy. And the reason why we don't operate on both sides of the brain is because the critical structure there that's often involved in generating seizures is the hippocampus. And the hippocampus is known to be involved in memory and learning. And when we operate on one temporal lobe, we believe that the other temporal lobe takes over the functions which we have either have not been sort of working well because that area of the brain is generating seizures, or because we're going to remove. And so we have to do the test and make sure that an individual, that other side of their brain can support that memory. And that's why once we've operated on one side, that reserve or that requirement for memory prevents us from doing anything on the other side, specifically as it relates to temporal lobe epilepsy.
Thank you. There's a question for Gary. Really, what sort of research is Epilepsy Canada supporting at this point?
A great deal. We've had 2016, and we made a decision to try multiple year projects. We weren't quite sure whether to go down that path or not. And so there were 4 projects, 3 in Montreal and 1 in Toronto. So we funded Dr. Peter Carlin's work on organoid work with brain cell technology and skin grafts. We've done high-end MRI research. We've done suit-up surgery, and those were both in Montreal. They've been varied. We try and pick projects across the country. We've done research in Saskatchewan, BC, Ontario, Quebec over the last 5 years. And this year, we're currently working with Cure Epilepsy to do a new investigator award. And we have 9 candidates that have submitted proposals, which will be approved sometime this spring. But we take a novel approach. Dr. Elizabeth Donner is now is the chair of our scientific research committee. And Elizabeth will be in charge of evaluating those projects. And it's up to the scientists to determine what avenue we should go down in a particular year. But we try and change it from year to year from this point on. Hopefully that answers the question.
Thank you, Gary. There is a question about a pediatric surgery, a child that is 10 months old with seizures that have been refractory to 3 medications. Is it possible to do surgery on babies that young?
Yep. So in fact, there's a network, a pediatric network throughout Canada, which published, really amazing data that shows that actually intervening early. Of course, there's different kinds of risk in the infant. However, that it's really a testament to the plasticity of the brain, where these young children or infants who have epilepsy, their sort of milestones can come back once you've removed that focus and if they're able to be seizure free. And so it definitely is worth exploring if your child has not responded to medications and continues to seize, the possibility of epilepsy surgery.
Question for Jordan. Jordan, you said you were back to normal at 2 months. Could you go back to work then? And did your recovery really last 2 months, or was it longer?
I did not return to work right away. When I say I returned to normal, in my mind, meaning I could get out of bed on my own and I could leave the house and see the world again, not relying fully on others, to get my food and drink. I felt alive again, and my head had returned to normal size. That's what I mean. So after 8 weeks, the migraines were gone, all the pain was gone, and I was sleeping better.
About how long would it take before you want to go back to work after seizure surgery?
I believe I took maybe 4 months.
Okay.
Yeah, but at the time I was a college professor, so it involved standing a lot and speaking a lot, and I had the luxury of waiting until the next semester. I didn't need to be there because they were in the middle of a semester, so I had the luxury of waiting. And but I could have returned after those 2 months if it was light work, without demanding too much physically. I could have returned.
Hey, thank you. Taufik, there are a couple of questions about vagal nerve stimulation.
Yep.
What is the wait time for vagal nerve stimulation?
So the longest time really still remains sort of the surgical workup and sort of to determine whether or not you would be a candidate for VNS, which is, as I mentioned earlier, is a bit of a diagnosis of exclusion if we really try to find that area of the brain where we can remove it to try to help with the seizures. By the time that, if somebody's referred to me for surgery, which means really the day after that they're seen or reviewed at our epilepsy rounds, then the wait time is approximately 2 to 3 months. Right now, though, I'm operating about 50% of the time, 50% of what I used to, but we're ramping back up now to sort of 100%. And so I would say the wait times are close to 2 to 3 months from the time that you referred to my clinic for surgery.
A question about a 3-year-old with tuberous sclerosis and refractory epilepsy. His EEG is very active. Would extended video EEG perhaps be enough to determine whether seizure surgery was an option?
So I think I sort of typed a response in, but I can definitely articulate kind of what I mentioned. So tuberous sclerosis is a bit of a complex problem because with tuberous sclerosis, there are multiple lesions within the brain. It doesn't mean, though, that surgery is not an option, but really what has to be proven is that one of those tubers is really the main cause of the ongoing seizures. And for sure, actually in the adult population, I have done surgery like that. It really, one has to really prove that there's one dominant one, there's not multiple tubers that are in fact causing the seizure. So surgery is definitely an option. I'm not an epileptologist, so I can't speak to the specificity and sensitivity of prolonged EEG. Of course, if surgery is a consideration, then one always has to go through the epilepsy monitoring unit and to have long-term recordings. But as an outpatient, it's not sufficient to make that diagnosis with just routine EEG or sleep-deprived EEG. One really has to come into the epilepsy monitoring unit to make that determination.
Okay, yeah, thanks, Taufik. Thanks, Gary. Thanks, Jordan. We've reached 4:45, and we're about to end the Facebook broadcast and to go into our breakout group sessions. But before we do that, we'd just like to say we appreciate everyone joining us here today. Our next webinar will be next Friday on March 12th, and it'll feature talks about memory and epilepsy. Our speakers will be Mary Pat McAndrews, one of my co-directors of EPLink, and Wendy Morris. There'll also be a Meet the Experts webinar on March 19th, and then a Purple Day celebration, which will be an hour and a half on March 26th. And we hope all of you will join us then. In addition, please send us your feedback about this event. There'll be a survey found at the following link, and the link will be emailed to you out after the event. Okay, that's the end of the Facebook broadcast. And